guess I will go ahead and get started. Okay, I think Anne and Kathy are on here. Hi, so thank you guys for joining me. You guys know me. I'm currently finishing up my bachelor's program at Vincent's University. Throughout this program, we have worked on a PICO question, focusing on something that could improve something on our floor. I focused on fall prevention, more focus in admission assessments, just the shift assessments we do on establishing whether a patient's a fall risk or not. So that's what my presentation is going to be over, and that's what I'm going to explain to you guys. So let's get started. So the issue is the need for a more in-depth fall risk screening. So according to networkofcare.org, Moore's Fall Scale, the problem is to reduce falls on medical, surgical, and intermediate care units. Fall risk screenings need to be more in-depth rather than just a fall history, take into regards medications, ambulatory aids, extra equipment, so like IV poles, Foley catheters, SCD machines, comorbidities, and mental status. So are they alert and oriented, sundowners, that kind of stuff. So some evidence-based guidelines regarding this. Falls are the most common accidents in hospitals that is reported. There's a lot of evidence-based studies to support falls because it is such an issue. According to the Joint Commission, falls are the result of ineffective communication, ineffective assessments, low staffing, lack of leadership, and the lack of adherence to safety protocols. So for this, the Joint Commission suggests utilizing teams to assess fall risk screenings and implementations, educating staff on screening tools, and also making plans to reduce falls. So as we know, the issue's falling, mostly in hospital settings on acute care floors. According to the Agency for Healthcare and Research Quality, 700,000 to 1 million patients fall each year in a hospital setting, and a third of those result in an injury. According to the World Health Organization, a fall is an event that results in a person coming to rest inadvertently on the ground floor or any other lower level. So that's the definition of a fall. So there's a lot of negative outcomes associated with patients falling. So according to the Patient Safety Network, so we know a third of the patients that fall result in an injury. A third of those patients, the injury is a fracture or a head trauma. According to the Journal of the American Geriatric Society, in 2015, $50 billion were spent in healthcare setting related to falls. Fatalities from falls resulted in $754 million. Medicare and Medicaid covered 75% of these costs, so that's a lot of money. And according to the National Council of Aging, every 11 seconds someone is treated in the emergency room for a fall, and every 19 minutes an older person dies related to a fall. So there's a lot of evidence-based practice, there's a lot of literature reviews, a lot of studies have been done on how to prevent falls. So I'm going to go over some of those with you. So the first one is a study related to pharmacology and how it takes effect on patients and their risk for falling. So this study was done in 2018. Researchers monitored medications and their impact on making a patient fall. Some medications included benzodiazepams, antipsychotics, narcotics, cardiac medicines, just to name a few. This study was done at a long-term care facility. It was also done at on a medical surgical unit. 152 total patients were a part of the study. This was a part of a quantitative cross-sectional descriptive correlation study. They found there was a significant correlation. P was determined to be less than 0.05, and they got a 0.030, so it was a significant finding between falls and the medications that they accredited to the patient falling. So if a patient fell within 24 hours of receiving this medication, they ruled that it could potentially be accredited to the medication. So these researchers, their suggestion was to implement that into screening tools when determining if a patient has a high fall risk or not, looking at their medication profile and how that could affect them. Another study was done in 2017. It was called Evaluation of the Medication Fall Risk Score. This screening was completed in 2 urban care facilities in Southwest United States. An independent t-test was done. There was a positive correlation. P was 0.0030. So the positive correlation was between utilizing both a fall risk assessment and a medication profile. So they also took in just a universal precaution, but also how medications had an effect on patients falling. So these researchers just suggested, again, to use universal precautions, but also to take medication into consideration. The six-pack program to decrease fall injuries in acute hospitals. This was done in 2016. This study was made up of 46,245 admissions at 6 different hospitals on 16 medical units and 8 surgical units. This was a cluster randomized controlled trial. There was no significant data with this one, but researchers did find that they had a very successful rate of employees who completed this within 24 hours of the admission date. So although there was no significant data that whether it did or did not decrease falls, they did see these fall risk screenings being put in quicker when the patient was admitted. Another study, it was done in 2015, the study of the cutoff point of the NURS fall scale. It was comprised of a score for over 6 systems, so they looked at previous vault history, secondary diagnosis, ambulatory aids, intravenous therapy, so were they saline locked or did they have fluids going, their gait and transferring abilities, and their mental status, so again, were they alert and oriented. This study was done on 5 adult inpatient units. 100 fall cases were reviewed out of 134 cases. It was a case-controlled study. There was a 65% positive correlation. Patients who were marked as high fall risk and who actually fell, so 65% of the patients that were high fall did fall. And there was also a 94% positive correlation between patients who did fall, reported that they did have a fear of falling prior to falling. These researchers suggested fall risk screening tools should be implemented, including categories that I mentioned before. So the last one is evaluating individualized fall prevention for clients with medically complex conditions. So this trial was a little different. It was done in 2016. It was actually done in an outpatient clinic. So there was patients went to this clinic after they had fallen in a hospital setting. They did a pre-test on these, and they did a post-test, so that's how they kind of determine if this type of therapy was beneficial to patients who had fallen in a hospital setting. The tests they included were timed up and go tests, gait speed, fall efficacy scale international, and the 30-second sit-to-stand test. So all the categories had significant results from the pre-test to the post-test. So all patients did have an improvement, whether it was their gait speed, whether it was how long it took them to go from sitting to standing, all of them did improve. So they recommended to include patients in their fall risk screening and consider therapy for patients who have fallen to decrease their fear of falling. So that was all the literature review. So now the PICO question. So P stands for population. So our population is going to be patients in a hospital setting. I is intervention. So in this case, it's going to be the fall risk assessment tool. C is a comparison. So comparing a new fall risk screening tool to the one that's previously used in our facility. And O is outcome. And the outcome is to reduce the number of patients who fall. So some theoretical framework, according to nursingtheory.org, the Newman model is a preventative goal. It's mostly aimed at primary prevention. This theory aims at preventing stressors related to detrimental effects on the body. This theory goes hand in hand with fall risk screenings. They both emphasize the importance of preventative care, so fall risk screening to prevent the patient from falling, to prevent those further injuries. So Newman and the fall risk screenings go very hand in hand. So the design that I would propose would be a quantitative research study, quasi-experimental design. It would be conducted among 3 units, so medical, surgical, and intermediate care units. The patients admitted to these floors above the age of 18. It would be conducted over a 1-year span, so 6 months with a controlled group, 6 months with an interventional group. The control group would be the standard fall risk screening that we utilize now, and the intervention group would be that same screening but implement categories, medications, secondary diagnosis, ambulatory aids, etc. So the screening tool would continue to be used at admission, each shift, and as needed, as we currently do it in our facility. This would be done on every patient admitted to the unit, so they would take audits from these. Patients' right and confidentiality would always be respected. Nurses would always be responsible for the patient's safety, first and foremost. No names, medical diagnosis, or medical record numbers would be included in any of this. The only information would be age, gender, and whether they were a fall risk or not. So a similar screening tool was done at another facility. It was called the Fall Prevention Toolkit. It was a 3-step process. It included conducting a fall risk screening, developing a fall prevention plan for that patient, and implementing that plan along with universal precautions. The reliability of the test is good. The researchers in this particular article saw an 80% compliance with conducting the screening tools. In addition, developing the plan and following through with it. The validity of it allows for diverse institutions, so each institution that utilizes this could modify it to their facility and how it would work for them best. So the new screening tool would include questions related to a patient's fall history, as we do now. Have you fallen in the past 3 months? Current medications, comorbidities, mental status, and additional equipment, SCDs, IV poles, things to that nature. Telemetry boxes. So audits would be done related to, as they audit us now, whether those assessment screenings are being done and if they're being completely filled out. Audits on occurrence reports from patients that have fallen. Also nurse leader rounding. They could look for universal precautions in the room, bed alarms, clutter-free, proper lighting. Also assess patient and family members' awareness of the fall risk plan. There's also visual aids where it's basically the screening tool, but the nurse can mark off the boxes so the patient is able to see what makes them a fall risk and hopefully encourage them to use their call light if they would need it. So this would be an independent t-test to assess the statistical difference between the two means. The level of significance would be greater than 0.05. The means that would be compared would be based off audits, like I said, gathered from fall risk screenings, visual aids, universal precautions in patient's room, patient family members' awareness of the fall risk plan, and falls reported in the EMR. So in conclusion, falls can be detrimental to a patient physically and emotionally. It's important to take several considerations when assessing a patient's fall risk status. I've mentioned it before: fall history, medications, ambulatory aids, comorbidities, mental status, and additional equipment. And the method of implementation can be really easy to implement into our facility. It'd be no difference, just a few more questions in the screening tool. So that's all I have for you. I know my internet connections went a little in and out here, but I appreciate you guys listening. Thank you and have a good day.